last paper, minimal invasive ileal pouch anal anastomosis with rectal eversion allows for equivalent outcomes in continence, from Dr. Boomer from the Ohio State University Wexner Medical Center.
Good morning. Thank you for the opportunity to present. We have no disclosures. Ulcerative colitis very commonly presents in childhood and adolescence and is more likely to present as severe pancolitis in younger populations. Similar to in adults, total proctocolectomy with pouch reconstruction remains a surgical treatment in children, and a doubled stapled pouch is often performed. However, low stapling, low anastomosis can be difficult. The technique of rectal eversion has been described to allow for precise identification of the dentate line and for assistance in this with laparoscopic procedures in the low stapled anastomosis. However, the concerns have been raised that this may lead to sphincter injuries and increase in incontinence. Almost all of the IBD patients at our institution are cared for by a single surgeon, and most of them, because of presenting with severe pancolitis, undergo a 3-stage procedure. In 2009, our primary surgeon transitioned from performing open procedures to undertaking a laparoscopic approach. And at this time, he also undertook the technique of rectal eversion for his laparoscopic J-pouch constructions. So the purpose of this study was to evaluate the outcomes, focusing on continence for the patients undergoing ileal pouch anal anastomosis for ulcerative colitis at our institution. This was a retrospective review at this single institution. We pulled all patients undergoing colectomy and subsequent J-pouch for review. We analyzed demographics, intraoperative data, length of stay, and postoperative outcomes, focusing on continence. At our institution, the procedure is begun by ileostomy takedown, and the J-pouch is then created extracorporeally through the previous ileostomy site. The laparoscopic completion proctectomy is then performed, and the rectum is everted and stapled at the 2 centimeters above the dentate line. An end-to-end stapled anastomosis is then created. Most of our patients also undergo a loop ileostomy at this time. A total of 47 patients were identified that had undergone total abdominal colectomy. We excluded the patients that had not yet undergone J-pouch reconstruction, and there was one patient that did have a laparoscopic procedure without the rectal eversion technique that was excluded. These 33 patients are utilized for all the intraoperative data and outcomes, and then 2 patients had not undergone ileostomy takedown yet, so those are excluded from my continence evaluations. So of the 33 total patients that were evaluated, 25 had undergone either a laparoscopic procedure or a robotic-assisted procedure, and those were considered together in the MIS group. The other 8 patients had undergone open procedures without the rectal eversion technique. There were no statistically significant differences between age, BMI, sex, and race in this population. And there were also no differences between operative time, postoperative length of stay. We did notice that there was a significantly longer time to ileostomy takedown in the open group, although we recognize this may be a change in practice over time, since most of the open procedures were performed before 2009. Complications were also similar between the 2 groups. A large number of patients did experience at least one episode of pouchitis. However, again, there was no difference between the 2 groups. There were also no differences in SSIs, 30-day readmit, or bowel obstructions. When looking specifically at continence, we evaluated 4 different measures. All of these measures are recorded by the gastroenterologist at every single visit to their clinic. There were no differences between the groups in regards to number of stools per day if they had to get up to stool at night, experiencing any amount of stooling, or having to take stool-altering medications. And those evaluations are at the 12-month follow-up. We saw similar results at both 1 and 6 months. So there are some limitations to this study, as there would be with any retrospective review. It's a single-center, small study with primarily 1 surgeon involved. And again, this surgeon converted from the open to the MIS techniques in 2009. So that would lead to a bias and with changes over time in the practice. Additionally, the rectal eversion technique may confound with the laparoscopic procedure. However, based on these results, we do feel that the rectal eversion technique is safe and effective for minimally invasive procedures and may assist with a complete proctectomy without any changes in continence in our patients. Thank you. I'm happy to answer any questions.
NWOMETH from Los Angeles. I have a question regarding what happened with kids who have a rectal disease. Are you approached the same thing? And how you surveilling them, especially if they still have a retained mucosa that potentially can cause problems in the future?
Sure. So these patients are all seen very regularly in a multidisciplinary IBD clinic with surgery and gastroenterology and are surveilled regularly. Although it's 2 centimeters, we are able to get fairly low, and then part of that 2 centimeters is also resected with the EEA stapler. If they had significant rectal disease, most of those patients with significant rectal disease have not undergone pouch reconstruction at this time.
Okay, thanks.
Oliver Munster from Mainz. Really, I have to congratulate you to actually follow them up so, in detail, especially their stooling behavior. That's very good. That's often what we don't do enough. We do it in Hirschsprung and in perforate anus, but not for these kids. In my experience with precisely that technique, there is a lot of post-operative soiling, a lot of difficulty, and I would say that this is something that we should look prospectively and then really compare one or the other. I'm not sure that we have the best therapy for these types of kids yet.
I think that's a great point. Like I said, I only showed the 12-month data, but we had no statistically significant differences in either the 1 or 6-month follow-ups either. I think one thing is to help to try to avoid some of the traction. This is stapled off at the peritoneal reflection, and that entire segment is pulled through, so you're not having to grab really close to the dentate line to pull it out for the resection. So.